Welcome to the VHQC Community to Community Care Transitions webinar. My name is Rebecca, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. If you have a question or comment, press star, then 1. Please note that this conference is being recorded. I will now turn the call over to Carla Thomas. Carla, you may begin.
Thank you so much, Rebecca, and good afternoon, everybody. It is my pleasure to be with you today, along with Kelly Arthur from our Care Transitions team at VHQC. For the next 30 minutes, as we proceed with our second call in our Care Transitions series, I'd like to encourage you to be fully present and engaged. I know it's easy to be distracted and multitask, but we anticipate a lot of sharing, and hopefully we'll take away some great ideas. I encourage you to be open-minded to some of the concepts, be willing to collaborate, and participate by sharing later on in the call. We have another opportunity for you to share throughout the call or ask questions in the chat box, either to the right of your screen, depending upon how it shows up, or if you have a full screen view, it could be at the very top of your screen. Just pull it down through a simple mouse click. So please feel free to join the conversation there, as well as later in the call when we open up the line. Like we've mentioned, today's webinar is part of a series, and each 30-minute lunchtime webinar is focusing on a specific topic related to Care Transitions coalition work. We hope that you will take away a tool or an idea that can really make a difference in your local coalition, and we'd like to feature at least one community coalition and hope that you will use this forum to make connections with others across Maryland and Virginia. We typically hear questions from coalition members asking what others are doing across the region. So we anticipate that this could be your opportunity to hear more from people doing the same work that you're doing locally. Before we get started, I'd like to encourage you to mark your calendar for the next call, the next webinar in our series on August 9th, where we will talk more about tests of change and the improvement model. How do you work together to take those steps toward improving many different opportunities that are identified in coalitions? So we wanted to just encourage you to save the date. More information will be coming to you soon, as many of you are on our mailing list. We're currently working with a number of communities in our Care Transitions project at VHQC. Currently there are 6 in Virginia and 4 in Maryland. We have a number of representatives on the call today from many of the communities shown on this map. The featured communities are on today's call are really all of you. We felt that to talk about today's topic, it would be more helpful to hear what others are doing across the state instead of just one community. So later we'll open up the lines to give everyone a chance to share after I make some opening comments and introduce the topic, which is structuring your coalition for success. Getting people to really come together around a cause and asking people to commit to the effort is very exciting. And we experience that with many of you in your coalitions across the region. Determining the best way to organize people and provide a structure to do that work in can be a challenge. And one of the biggest fundamental questions that is asked related to coalitions is, how do you get the work done together? How do you organize people and activities? What works? What doesn't work? Without consideration for structure, you really could have 100 people in a room excited to be part of an effort, but lose their enthusiasm very quickly without structure. Several considerations need to be factored into your coalition structure. There is no absolute right way to structure your coalition, but you really need to take into consideration your location, the geography of your coalition. Are there a number of hospitals engaged? Are there a number of members who are affiliated with different organizations, or sustained parent organization, or is your area pretty rural with people widespread and having to travel to get to a meeting? There are different relationships and history of members, who is doing particular work that aligns with the coalition's effort. So the thing that we're wanting to consider is, how do you organize and get people aligned to do the work that the coalition identifies as it's evolving. I'd like to encourage you to type in some ideas for things that you consider related to structure in this chat. Now, what I have in the next few slides are some examples of different ways that groups have organized in the past. In the care transitions work, as coalitions and collaborations have started, there tend to be pairings. A hospital might reach out to some nursing facilities to identify some opportunities or share some best practices. A hospital might work with some home health agencies or hospices in smaller sizes, smaller groups, and then they might come together occasionally to share what's working. There might not be formal improvement efforts, but this could be just general sharing. This is sometimes where more formal coalition structures start, just smaller groups and pairs. Some coalitions structure their work with setting-specific groups. And very often we see skilled nursing facility work groups in a structure. Home health agencies might spin off and work on a particular topic. It really depends on the topic. The question becomes, do you organize based on topic? Do you organize based on setting? And that might be determined by the size of your coalition, the location, as well as the opportunities. So it really is up to your group to determine how you want to do that. And it could change over time, too. But setting-specific groups are really usually trying to hone in on a particular challenge related to that setting that could spill over into other settings. So the goal is really about integrating efforts and avoiding duplication of effort. Now, the cluster model is used quite a bit in areas, sometimes when there are more rural areas and a hospital might have their local referring providers that they work more closely with. There might not be as much overlap, and we have some coalitions that meet less frequently as larger groups, but more frequently as smaller cluster groups. And this can be a nice way to build a coalition if there are if there's some distance between providers and hospitals. And this can create a nice community effort. The question here is, who is coming together to connect the clusters? So for that community-based effort here, you want to look at who is representing each of the clusters. Are they representative of different organizations and settings and systems? So can they report back to the larger regional group for their local effort? Some people add on a steering committee, and that's answering the question that I just posed. This steering committee model really is determined by the members of the group as like I said, it really should be inclusive of the provider setting and the stakeholders in the community. This is just another way of looking at it. It is kind of a top-down, it's more spread out. Representatives in work groups could be from each cluster or representing multiple clusters depending upon what the work groups are for the community. So those are just some ideas that we've seen out there, but I'd like to present an idea to you related to structuring your coalition, and that is the one of leadership. And as we talk about coalitions and developing them, it's really about organizing leaders to encourage their leadership to work together to solve their own problems. And many times it's in the face of uncertainty because there's so many different options and opportunities. So if we think about how coalitions are led, if you're thinking about how you're encouraging people to lead within this type of community effort, think back on how you ask people to lead. And this is one way that many of us are very familiar with. We typically see this in healthcare settings. And it really is best for efficient processes and productivity and bottom lines. It makes clear who's in charge and what gets done. But if this model is poorly executed, it really is more of a command and control center, which is good and it has its place. But if you're trying to encourage people to be more empowered and more part of the solution, this kind of structure can really could lead to some disempowerment if people cannot make decisions about the things that affect them. And that's what the element of leadership within a structure does. I know I've been in this position before as the Lone Ranger, leading a group forward where, and I've seen this happen in coalitions where one person is solely in charge of doing everything. Everything flows through that Lone Ranger, and that dot in the middle can get very lonely. And the whole coalition rises and falls on whether that person is available and has time and can get things done. So this model is not sustainable. We've learned that working with several coalitions, and you really need a group of people to help. If you do get groups of people together used to leading in their own organizations, this model can also be challenging, where you come to a meeting and then you go back to your own place. And typically, when you have a lot of leaders taking the work forward, no one can be responsible in this kind of model. So everybody comes together, but then they go back and do their own thing. So you really need to look at how to coordinate a shared purpose. And in general, coalitions are designed to overcome these kinds of challenges. How do you get the work done together? And how are you going to structure to do that? So I'd like to introduce one model called the Snowflake Model that we have introduced to several of you that we're working with in communities. This is the Snowflake Model for Interdependent Leadership. It is developed by Rethink Health, and they work quite a bit with coalition development. And this is a proven model that relies on it goes from the middle out, but it just doesn't go out, it comes back. So the multiple arrows really are showing that the leaders make mutual commitments to one another and enable each other to really achieve a shared purpose. It's really about creating a powerful collective effort. So typically, the middle could be a leadership team or a core group of representatives from the coalition that are looking at the bigger picture and connecting with leaders that could be affiliated by topics in the community or setting, branching out to ask other leaders to help with initiatives. So that communication goes back and forth, and this model is built on communication and commitment, not only to each other, to the opportunities, but to the entire effort. So at this time, I'd like to ask all of you what type of structure your coalition is using now, how it has evolved, how it's working, will it change, and has your coalition organized, how is your coalition organizing to accomplish improvement activities? It might all be in the same answer, but we'd like to hear from you. This is a short call, and so I want to open the lines at this time to ask anyone on to share, to answer these questions. Rebecca is our operator, and I believe that if you press *1, you can get in queue to share. Sitting right next to me in Lynchburg, Virginia, during today's call, which came right after a coalition meeting, is Dr. Jim Dunston. And he is one of the leaders for the Blue Ridge Care Coalition Collaborative. Blue Ridge Care Collaborative. And he is volunteering to share their experience with the Snowflake Model.
Hello, everyone. I am the physician coordinator, and I think that's a good name for the person who brings everybody together in the leadership role. That way you're protected from having all those arrows point at you, as you saw earlier. So we're 6 months into our collaborative. We've named it. We've had various folks sign charters. We're still building our leadership team. We have a lot of Centra people, the main hospital system in our area, a lot of representatives from there. We're reaching out to other community members, slowly building, finding that appropriate leader and collaborative person. We also have, as Carly's shown in the Snowflake model, different segments of the crystal starting to operate. And the advantage of this is you're not limited. If one begins percolating, then that informs the other group. They report into the leadership team. The leadership team can report out to them. So the interconnections are important. The other thing about the Snowflake model is it's eminently changeable to fit your particular community. So this is working well for us as we build. We can address certain aspects and get traction on them as some of the smaller subgroups work. Then we can change the focus of the leadership team to dedicating resources and access to hospital facilities, other community facilities that could be working to bring about the change we want. So Paula has introduced this concept to us, and at this point it's working well.
Well, thank you so much for sharing, Jim. That was discussed today during today's meeting, just trying to figure out if it's addressing all of the right opportunities and all of the circles are where they need to be at this point. So, thank you very much. Rebecca, do we have anybody on the phone who's willing to share?
Yes, we have a few questions or comments. Kathy from Holy Cross Health.
Hi, Kathy.
Hi, Carla. How are you?
Great. How are you?
Fine, thank you. So there are actually several collaboratives going on in Montgomery County right at the moment, and I'm going to talk for a minute about the hospital work group, because this is a coming together of the 6 hospital care management and population health staff. And I haven't heard of the Snowflake model, but I think that it fits for that group. That I think of it more as collaborative. I mean, there's not an identified leader, but we've agreed to come together and we agree to work on common projects. And so anyway, I think of it as more collaborative, but I think it fits Snowflake. There are a couple of other collaboratives. Go ahead.
Great. I'm glad that could be a useful tool.
Yeah. There are a couple other collaboratives going on in the county. One is called Health Partners, and it actually started with one hospital and one HOC housing community, but it actually has evolved into a much larger community project that they're hoping to be able to replicate in other senior housing buildings. And that also, I mean, I think Primary Care Coalition took over sort of the facilitation of that group. So there's at least, identified facilitation, but that group has grown tremendously as they identify needs and they invite in additional partners that can address those needs. So it involves, again, hospitals, senior housing, primary care physicians have attended. They've even got involvement of the 911 community. I can't even think of who else was involved, but that's quite a thriving coalition, and it is fed into now what's called Nexus Montgomery, which is an enormous grant that we just got from the state for the county to work on a number of initiatives, but one of them will be sort of expanding the health partners work. So it'll involve really geriatric care management in 22 independent senior living buildings, trying to identify residents before they have a health crisis and improve health in general and reduce hospital utilization.
Well, thank you so much for sharing. It sounds like, there's a lot of different structures within several different efforts in your local community that probably overlap or touch together.
Yes, I think there is overlap, but it's a common community participating in the different branches as appropriate. So I think everybody is familiar with what's going on in all the different places.
That's great. Thank you so much for sharing, Kathy.
Thank you.
Rebecca, do we have anyone else on the line?
We have Karen from Calvert Memorial. Your line is open.
Hi, Karen.
How are you?
Good. What's your structure like out in your neck of the woods?
I think we're a hybrid of the leadership in the Snowflake. We're evolving. What we've done at Calvert is a tiered system starting with our local community and then linking over to a tri-county collaborative, which then links into a larger coalition of federal hospitals and agencies across multiple counties. But looking at our local coalition, what we did out of the gate was to open our doors to not just our skilled nursing facilities and home health agencies, but any of our community resources, inclusive of the health department, local pharmacies, et cetera. We invited some of our most commonly used vendors and folks that ran programs in our area to join us. And we started off by identifying where people felt there were either breakdowns in communication and collaboration, where we had gaps in service provision, and developed a goal-centered charter off of that, really taking a look at not just decreasing readmissions, but working a little more efficiently and effectively with each other. Our goal was to make sure that our community received the right care in the right setting at the right time. We initially centered around how to improve communication, and we tried to find a level platform for us to partner on. So we chose implementing a communication transition tool, Kirastan, e-discharge is what we went with, and used that as a leaping off point of quick success to get folks engaged. what we've done with our meetings is probably a little bit different. We do now meet every other month as a coalition. We had been meeting monthly. We have a skilled nursing facility subcommittee focusing on Interact implementation. But with our core group, what we've done is structured the meeting so that there are core topics that we have at every meeting. We allow one organization to spotlight themselves, so they have 15 or 20 minutes to talk about their organization, who they are, services they provide. We provide an educational segment as well, new products, to be a variety of things. We incorporate data into every meeting, so we find someone to bring forward either data from their specific organization. It could be quality, satisfaction, readmission. And then we do a case study, something that we've partnered on where we can share lessons learned about how to manage a specific patient. What we found is by putting this in place, it has allowed us to partner better. And it has really allowed us to work on how we collaborate as well. The last thing that we've recently done is we rotate our meetings. We started meeting at the hospital, but now we actually rotate to our community partners so that we have the opportunity to see their organization, meet their staff, and to, again, have a better idea of who we're partnering with in the community.
Thank you so much, Karen. Lots of moving parts there, but all connected for the same goals. It sounds great. Thank you. Rebecca, does anyone else in the queue?
We have no other comments. If you have a question, please press star then 1.
Okay. It doesn't look like we have any questions or comments in the chat at this time, and we are close to top of the hour. So I will...
I'm sorry.
Go ahead. Did somebody come through?
Jay from VCU Health. Your line is open.
Great. Hi, Jay.
Hey, Carla. Just really quickly, I know we're at the end of the hour, but I wanted to mention what we're doing here in Richmond. You've been very instrumental in helping us strategically organize, and our structure is evolving like some of the others. I think we're a bit in our infancy, but we've been a committed leadership team. We've got sort of a lean structure now with chartered members that are committed to the effort. It started around the data and the ability of the QIO to organize a coalition of hospitals, and then we worked with the AAA in the Richmond region as well as a representative from our affiliate organization that represents post-acute providers. A lot of our work that is built trust has been around grant opportunities and, again, this data that's representative of the region's efforts around readmission and cost containment and improved outcomes. We do have consistent meetings. We've been doing that monthly, 90-minute meeting. We're now essentially determining how to best accomplish the work that we want to achieve together. Ultimately, we'll evolve to something like you've described in this Snowflake model, where we'll have subgroups organized with focused endeavors that will report out to our leadership committee. That's the hope. Some of the early goals that we're targeting are, again, like some of the others have described, some leaping off points for quick success. So we're focusing now on communication, suggesting using Interact tools and working closely with skilled nursing facilities on creating inventory checklists and transition forms that can be shared across the providers in the Richmond region. So we've had an early start, and we're looking for great improvements across the region, and we appreciate VHQC in helping us address those needs.
Thanks so much, Jay. I appreciate your sharing. Okay, in the interest of time, looks like we are at the top of the hour, and I want to thank everybody for being on this session today. Hopefully you've taken a few ideas away that you can discuss with your coalition and share for continued success. I want to remind everybody that we do have an online care transitions community. The sign-on link is right there on the slide, and we do follow up. That is also sent out to you with the webinar, that link. If you have any questions, feel free to contact myself, Kelly Arthur, or Cindy Warner. We look forward to seeing all of you out in your communities very soon. There should be a session evaluation posted. We appreciate your feedback for future webinars. And with that, I will wish you all a great day. Thank you so much.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.